my pleasure to introduce our first speaker for the day. He's called Dr. Dharshan. Dr. Dharshan is an associate professor at the Department of Nephrology at the Kasturba Medical College. He got his Academy of Higher Education in the India and has done an advanced pediatric renal fellowship at the Sydney Children's Health Network. Dr. Dharshan today is going to be talking to us about darbepoetin and the use of darbepoetin in chronic kidney disease. So welcome, Dr. Dharshan.
Yeah, thank you for the kind introduction, Dr. Baga. If someone can let me share the screen. I'm just disabling my video so that sometimes the internet bandwidth may not hold with the video. So I'm just currently I'm attached to the New South Wales Health Sydney, and it's good evening from Sydney and good afternoon at Kenya. Thank you, Kenyan Renal Association, for having me today. My topic for the day would be just to summarize the management of anemia in chronic kidney disease. KDIGO published its first guidelines for anemia in chronic kidney disease in the year 2012, and not much, I would say, progress has happened in the field of anemia in chronic kidney disease. In fact, not much progress has happened in the last 60, 70 decades. After the erythropoietin discovery and FDA launched in 1989, it's been the backbone of anemia management in chronic kidney disease. I'll just talk through at the end of my lecture about the newer molecules such as the HIF inhibitors and the EPO mimics, but more often my talk would be just to summarize what the current practice of management of anemia in chronic kidney disease in general. As my disclaimer said, the presentation is just a suggestion which would require local modification, and the current data, it's based on the current data, but with more data coming in the next decade, things may change. As we all know, anemia has been the most significant consequence of chronic kidney disease. In fact, it is one of the most symptomatic consequences of chronic kidney disease. Patients become symptomatic from anemia much early in the earlier stages of chronic kidney disease. It's associated with a reduced quality of life and definitely with increased morbidity and mortality. As we all know, treatment mainly involves the erythropoiesis stimulating agents and the iron supplementations, and most often follow the clinical practice guidelines, which has been laid by either by the National Society or by the KDIGO. What happens if anemia? Why is it necessary to correct the anemia? We all know its consequences on the heart results in high cardiac output, an increase in the peripheral vascular resistance, chances of MI, and ventricular hypertrophy. These are some of the consequences of anemia, and that's one of the reasons why we need to correct anemia. Other than its effect on the heart and blood pressure, what we also know is it reduces the quality of life, reduces sleep, cognitive function, in fact, the sexual function. You become extremely fatigued. So these are some of the non-cardiac secondary effects of anemia. And we know that correction of anemia is itself an issue because it can lead into, especially with use of erythropoietin stimulating agents, there is a risk of hypertension and vascular access thrombosis. So let's come to the definition about what we talk about erythropoietin and when do you need to use it and what is anemia. So these are the various guidelines, and what we often follow is the KDIGO guidelines, which were published in the year 2012, hemoglobin less than 30 in an adult male. When they say adult male, it is anyone who is more than 15 years of age, and in females, it is less than 12 grams per deciliter. In children, KDIGO defines various cutoffs between 6 months to 5 years. It is about 11 between 5 years to 12 years, it is 11.5, and then between 12 to 15 years, it is less than 12. So in children, the guidelines from KDIGO is different. NICE is very conservative. If you look at all the guidelines, NICE is very conservative in defining definition of anemia. Yeah, as we all know, as we progress across the stages of chronic kidney disease, the incidence of anemia gets worsened, and when someone is at the stage 5 chronic kidney disease, 80% of them tend to have a hemoglobin which is less than 30 in males. We see this difference because of the cutoff. KDOQI has a cutoff of 13.5 and WHO has a cutoff of 13, and that's the reason you have difference in the graph between the incidence of anemia. Why anemia is why correction of anemia is so as an important consequence, and we have seen that as we told, that not only the quality of life gets affected by anemia, but also there is an increased incidence of mortality. This was the data from the USRDS, an older data, 2002, but what it said, it was with anemia is a multiplier for mortality. If someone had only anemia, there was an increased mortality rate by 2 times. If someone had diabetes with anemia, it jumps to 3.6. In a diabetic with a heart failure and anemia, it is 4.6. If someone had that, the mortality increases to 7.5. So this was how anemia is a multiplier of mortality. This is one of the best graphs to indicate any comorbidities or without comorbidities, anemia itself can result in increased mortality. In fact, when we see this graph, diabetes also, along with not just anemia, diabetes is also a multiplier for mortality in chronic kidney disease patients. And this combination is highly dangerous, diabetes with anemia. So the prevalence of anemia in patients with diabetes is high. It is, in fact, diabetes with a normal renal function, they can have anemia as high as 32% of them. Some of them can be because of the older age, and also patients being on the thiazolidine therapy. In fact, studies have shown that the erythropoietin concentration are found to be lower in subjects with diabetes, even with normal renal function. There is also a significant inverse correlation between serum erythropoietin levels and the glycosylated hemoglobin. The worse the glycosylated hemoglobin, the higher the glycosylated hemoglobin, the lower is the serum erythropoietin levels. There is an inverse correlation. The prevalence of anemia was found to be higher in patients with macroalbuminuria compared to those with microalbuminuria or no albuminuria. Definitely, diabetes are more anemic and are more profoundly anemic compared to non-diabetic chronic kidney disease. When we look as an anemia, we all know that it is the relative EPO deficiency in chronic kidney disease which makes the anemia of chronic kidney disease as the epicenter. But what are the other causes? So this is one of the most comprehensive list, probably I would say, which includes the next after iron, EPO would be the iron deficiency, then the chronic inflammation. CKD itself is a chronic inflammatory state. Under dialysis, non-compliance to ESA therapy, any ongoing blood loss, and one of them could also be because of the pure red cell aplasia or hemoglobinopathies. So what is more important in CKD is there is a relative EPO deficiency, there is a chronic inflammation, and the iron deficiency. I'm not going to talk about on all these chapters, but I would just concentrate about the EPO in this talk, and probably a couple of slides on the iron deficiency. As part of an anemia evaluation, this is what in practice we all would do. We would just get a full blood count, or red cell indices, a retic count. Retic count is not only just tells you what the erythropoietin response is, or whether there is an ongoing hemolysis, ongoing blood loss. So what's the response of the bone marrow? So retic count is an important marker in evaluating anemia. And at all tertiary centers, I think we do have access to measure total iron binding capacity and serum iron and transferrin saturation. This is this serum iron, total iron binding capacity, TSAT, and serum ferritin are the standard routine measures for evaluation of anemia before we go on to start the erythropoietin or ESAs. These are some of the theoretical markers what we have, and probably it's more in centers which have access to the. Some of the advantages are they don't get influenced by ongoing inflammation. We know that hepcidin inflammation can interfere with some of the estimate, like ferritin can be high in presence of inflammation. So these are more accurate markers in the presence of inflammation. And they are also more sensitive, especially the reticulocyte hemoglobin content and the percentage of hyperchromic red cells. This is somewhat which has been started to come into clinical practice in some of the centers. As I told you, my talk today would be more on use of EPO and other erythropoiesis stimulating agents, especially the darbepoetin. Okay. So probably after hemodialysis, after dialysis, in fact, erythropoietin has been the mainstay of at least the innovation of in terms of renal medicine. There's not much newer molecules. Probably the more recent one is the SGLT2 inhibitor and the kidney, or the use of ACE inhibitors. So usually you can just count them on the major innovations that have transformed the practice in chronic kidney disease. It would be dialysis, it would be erythropoietin, ACE inhibitors, and probably now the SGLT2. So let's go to the history of erythropoietin. Even though it was in the 19th century, the early 19th century, when Carnot and de Flandre was first postulated that there is some circulating humoral factors which helps in erythropoiesis, and they termed it as hemopoietin. This was basically from their experiments from anemic rabbits. They would take the serum from anemic rabbits, inject into another rabbit, and they would see there would be marked erythropoiesis, and that's why they thought, okay, there is some hemopoietin kind of a humoral factor. It was for the next 5 decades, there was not much progress on this. It was only in 1953, Erslev definitely demonstrated the erythropoietic role of serum factors, which is now called as the erythropoietin. It was in 1957, Jacobson and co-workers provided an indirect evidence to suggest that kidneys were the primary source of erythropoietin. What Jacobson and co-workers did is they tried to remove each organ in the rabbit and try to identify the source of erythropoietin. They took out the liver, the erythropoietin production was still continued. They took out the intestine. So they kept on taking an organ, and finally they realized when they took out the kidney, the EPO's levels dropped. So that's when they realized, okay, kidney is the main site for EPO production. This was a paper which was published to mark the 80 years of initial innovation by Carnot and de Flandre. If someone is interested in history, a very good paper which talks about how the innovation across the years about erythropoietin. It was then Lecombe and Curie who demonstrated the cells which were responsible for erythropoietin production, and they said that yes, it's the peritubular interstitial cells, the peritubular fibroblasts located in the cortex and the deep outer medulla, which were mainly responsible for EPO production. They also identified interstitial cells were positive for erythropoietin mRNA, which are found in deeper cortex and the outer medulla. With increasing anemia, the number of positive EPO mRNA positive cells increases both in number, and it also spreads to the superficial cortex. These were the further experiments in the later years. So how the sequence of erythropoietin stimulating agents has come across through the years. The first FDA approved was the recombinant human erythropoietin alpha, which was approved in 1989, which was FDA approved in US. In the similar time, erythropoietin beta came into existence. Then came the second generation erythropoietin, that is the darbepoetin alpha. Then we had the third generation erythropoietin, that is the SERA, that is the continuous erythropoietin receptor activators, also what we know as the NERSERA. Then in the turn of 2000, they started erythropoietin mimetic peptides, which is the hematide, also known as the peginacetide currently. In the last decade, there has been much progress on hypoxic inducible factor stabilizer. There is again the first generation and the second generation. One of the second generation molecule is the roxadustat. I'll be speaking a little bit on these factors at the end of my session. And finally, something to look forward is the gene therapy in anemia management. What exactly does the erythropoietin do? We all know once there is hypoxia, it is sensed by the peritubular capillaries and the fibroblasts. There is an erythropoietin production. Erythropoietin now goes to the bone marrow where there is erythropoietin receptors in the progenitor cells. Basically, it's a growth factor. Erythropoietin is a growth factor. That is why when we say it is a growth factor and an anti-apoptotic factor. So the presence of erythropoietin, when it attaches, it helps for the myeloid precursors to progress through their maturation and to form what is known as mature RBCs. So if lack of erythropoietin, it will result in apoptosis, and that's when the anemia starts. So it is an anti-apoptotic factor, and that's why its use in the presence of active malignancy is always thing to watch for. This is how the erythropoietin receptors usually are. If you look, it's a dimeric receptor. You need to have a homodimer. So even whenever these are the cells, the erythropoietin receptors are exclusively present in the erythroid precursors. So what happens is once there is an erythropoietin molecule which binds to the erythropoietin receptors, they form dimer, a homodimer. Following the dimerization, there is the activation of the JAK2 and the STAT5 pathway. So we all know that in patients with polycythemia, we estimate the JAK2 and the STAT-K mutations. Look for the mutations. That's mainly because it's the pathway of phosphorylation of the JAK2 and the STAT pathway. STAT stands for signal transduction activator of transcription factor, and they again become a homodimerization. And when they become a dimerization, they go into the nucleus and helps in the activation of the gene. So it's basically a transcription factor. It acts like a transcription factor wherein which it attaches to the gene and helps in the activation of the gene. And mainly, this is how it helps in the progression. So we have two forms of erythropoietin which first came and which is there in the clinical practice available in most of the countries, erythropoietin alpha and erythropoietin beta. We need to know that you need a mammalian cell to produce erythropoietin. This is mainly because the bacteria lack a glycosylated, highly glycosylated molecule, and we all know erythropoietin is basically a heavily glycated protein. It's a bit and that's the reason you need a mammalian cell for it to be produced, and that's the reason the most common cell line what we use is the Chinese hamster ovary cells. Both erythropoietin alpha and beta have the same protein backbone. It is a 165 amino acid backbone. It's mainly the glycosylation which helps to differ the erythropoietin alpha and the beta. So normally when you start on an erythropoietin, you expect ferritic count to increase at least 2 to 3 times from the baseline. And you can see this by the 5th to 7th day after starting erythropoietin. You start a EPO, a single dose, or after 2 doses, you start the retic count going up 2 to 3 times. And what further you can see is the increase in the hemoglobin concentration of 0.5 to 1 gram per deciliter by the end of 4 weeks. The increase is dose dependent. The higher the dose you go, the higher the hemoglobin gets. But you don't want a rise of more than 1 gram per deciliter per month. This is mainly to prevent the adverse events, especially the hypertension, the stroke, vascular thrombosis. So make sure that your hemoglobin rise should not be more than 1 gram per deciliter per month. Subcutaneous administration is more preferred because it reduces the cost. It helps to reduce the dose of erythropoietin, and that's how it improves. It helps to reduce the cost. With darbepoetin, it doesn't matter whether it's an intravenous route or a subcutaneous route. That's one of the advantages of darbepoetin, especially in dialysis patients, because the dose is the same. It doesn't matter whether it's a subcutaneous or the IV route, unlike erythropoietin, in which intravenous route require higher dose. Always consider stroke, active malignancy, hypertension. They may be the ones which can interfere with the therapy. You need to be very cautious when using in these patients. So when do you start? Usually, if you're a non-dialysis chronic kidney disease patient, if there is a hemoglobin of less than 10 and you have evaluated completely and you know that the person is iron replete, is not iron deficient, and there are no other signs, obvious signs other than a relative erythropoietin deficiency, it is then you plan to start. Basically, the idea is you don't let the hemoglobin fall below 9. So as soon as the hemoglobin is less than 10, there should be a thought of considering erythropoietin. If you have corrected rest of the other causes, especially the iron deficiency and inflammation. So KDIGO suggests initiating erythropoietin stimulating agents when the hemoglobin is less than 10. Use of erythropoietin to maintain a hemoglobin of more than 11.5 should be individualized. Ideal target is to keep the hemoglobin between 9.5 and 11.5. If you are trying to keep a target more than 11.5, you need to be individualized. You need to have a valid reason why you want such a higher hemoglobin target, especially if you want to improve the quality of life. If someone feels the exercise tolerance improves if they maintain a higher hemoglobin, that should be individualized. In fact, you should stop using erythropoietin stimulating agents when the hemoglobin gets more than 30. How did we come to these targets, and what are the things? How did we decide we need to have it somewhere between 9.5 to 11.5? This has basically come through these trials: the normal hematocrit trial, the CORE, the CREATE, and the TREAT. The TREAT is basically darbepoetin was used in TREAT, in CORE and CREATE, and the normal hematocrit was more of erythropoietin. So normal hematocrit trial, I'll just go through a couple of slides among these trials just to talk through that. It was one of the largest trials trying to establish the best hemoglobin targets to achieve. So 1,200 patients on hemodialysis with a baseline hematocrit value 27 to 33, that is between 9 to 11 gram per deciliter. They were either randomized to achieve either a higher target, more than 13, or around 10. So the primary endpoint was time to death for the non-fatal MI. Study was terminated early because the first year and the second year mortality rate were higher in normal hematocrit. The normal hematocrit is nothing but the 13, that is the 42 group. So if you have a higher hematocrit, they were more likely to have mortality. So that's the reason the study was terminated, and they said that, okay, you can't maintain hemoglobin of more than 13 gram per deciliter in patients on dialysis. And they also noticed an increased incidence of thrombosis of the grafts and fistula in the normal hematocrit group. Then came the CORE, TREAT, and these were the trials which were the non-hemodialysis patients across various stages of CKD. And again, the targets were the same, to look for the cardiovascular event. And again, most of them had to terminate early because in all these studies, if you're trying to maintain a higher hemoglobin target, they were associated with higher cardiovascular events and vascular thrombosis. Similarly, in CREATE, as well as in TREAT. TREAT is the one where darbepoetin was used. And yes, I mean, overall, what they said was there was an increased risk of fatal and non-fatal stroke with darbepoetin, especially when higher hemoglobin targets were tried to reach. There was also an increased risk of death due to malignancy in the darbepoetin group whenever the higher targets were used. So, especially if someone has a past history of a primary malignancy or a stroke, you need to be very cautious. A couple of slides on the role of iron. Not much detail because it itself is a talk. So erythropoietins, if someone is on a EPO, you need to make sure that you evaluate their iron status at least 3 monthly. That's because with the use of EPO, the utilization of iron is more robust. ESA should not be started until iron status have been evaluated. With ongoing ESA administration, adequate iron stores must be continuously maintained in both CKD and dialysis patients. This is mainly because the iron gets, with more EPO, the iron gets utilized in red cell production, and that's the reason it needs to be continuously replenished. Nearly 10% of the hemodialysis population on erythropoietin who have been diagnosed as ESA resistant, that is nothing but erythropoietin stimulating agent resistance, have also functional iron deficiency. Functional iron deficiency, as we know, is someone with a TSAT of less than 20%, but a ferritin of more than 500. So you have a normal ferritin, but a low TSAT. And that's where you're thinking, okay, there is a functional iron deficiency. The iron is not getting mobilized, probably because of the increased levels of hepcidin, which is going to trap it. There is a direct correlation in which elevated hepcidin levels are associated with increased ESA resistance and increased ESA dosing. So elevated hepcidin levels are more likely to be responsible if the ESA dose keeps going up in a patient. This is just a simple example just to see what happens. Iron gets absorbed in the duodenum. Usually the second and the third part of the duodenum is where iron gets absorbed. From the ferric to the ferrous, it changes. It keeps moving when it goes into the cell and across the cell, it keeps moving between ferric and the ferrous states. Cytochrome B at the duodenal cells helps its absorption, and the protein which is required is the ferroportin, which helps in the movement of from the intracellular to the plasma. And it is this protein that is the ferroportin.
Juliet, the conference was postponed. Now, why am I not speaking? Not 3 o'clock. Is it written 3 o'clock?
Could you please unmute?
Yeah.
Thank you. It's basically the ferroportin.
That is ECMO.
It's the ferroportin, which is important in the transportation of the iron from the intracellular to the plasma. And this is the one which is blocked by the hepcidin. So if you see hepcidin blocks this iron transport of protein, and that's why iron gets trapped intracellularly, both in the macrophages as well as in the intestinal cells. And what happens is with these cells, as they increase turnover, the iron gets lost in the stools. That's coming to the route of administration, which one you want, which is whether you prefer the subcutaneous or the intravenous route. We all know that subcutaneous route is associated with, this was a study which was published in NEJ in 1998, which said that subcutaneous route helps in reducing the reducing the dose of EPO by prolonging the T-half of the EPO. So preferred subcutaneous. In non-dialysis, in dialysis dependent, it is the choice. It is up to the patient. If they can't tolerate subcutaneous injections, then yes, they can go for the intravenous. A simple conversion table. If a patient fails to respond satisfactorily, normally you try to start with the dose per kg. So you start with erythropoietin, you start with 50 units per kg, and with darbepoetin, you start with 0.4 microgram per kg per week. This is the initial dose, but if the response is not great, when I say response, there should be a rise in the hemoglobin of 0.5 to 1 gram per deciliter per month. If the rise is not adequate in an iron replete patient, then you up titrate. You initially go up by 25% and then you go up by 50%. Never try to go up by more than 2 times the body weight dosing. So the cap is 2 times the body weight dose. You don't try to go up over that. So if someone has reached the hemoglobin targets, let's say if someone has reached a target, if someone's hemoglobin is 11.5, you don't stop the EPO at that point. You reduce the dose. You can either space it out, you can either make it weekly if he's on twice weekly, or if he's on darbepoetin, you can make it once in fortnight. So you don't stop it, but you taper and reduce the dose of the ESA. So what do you mean by a large ESA requirement, large erythropoietin dose requirement? And this is basically excessive doses at the initiation or inability to achieve and maintain a target hemoglobin levels despite a large dose in an iron replete patient. So what is this large dose? According to KDO, 450 units per kg per week of intravenous erythropoietin or 300 units per kg per week of subcutaneous erythropoietin is the large ESA requirement, and this is known as, probably this will classify as an ESA resistance. The next thing is the revised European guideline says that 300 units per kg per week of EPO with a maximum capping of not more than 20,000 units. If you're using darbepoetin, a large ESA requirement is defined if someone requires more than 1.5 microgram per kg per week. So KDIGO, what does KDIGO say? It says that the initial hyporesponsiveness as having no increase in hemoglobin concentration after the first month of appropriate weight-based dosing, and an acquired hyporesponsiveness as requiring 2 increases in ESA doses up to 50%. When they say 2 increases, each increase is about 25%. So 2 increases is up to about 50% beyond the dose at which the patient had originally been stable. Someone was stable at 4,000 units per week, but then he starts dropping his hemoglobin, you go up to 6,000 units, further continues to drop, you go up to 8,000 units. That's what it is called as an acquired hyperresponsiveness. This again is the same table what I started with. If someone is hyperresponsive, again go through the same things: iron deficiency, chronic inflammation, hyperparathyroidism, hemolysis. You again basically go up with evaluate for the same things. A poor response to erythropoietin stimulating agent may be associated with increased mortality. If someone is requiring a very high dose of erythropoietin or darbepoetin, they are more likely to have increased mortality. A couple of slides on what are the side effects. Not much. I wouldn't be talking too much about hypertension because everyone knows that before starting EPO, you need to have the blood pressure below the 95th centile for the age. You make sure that the blood pressure is well under control, because 20 to 30% of patients who receive intravenous EPO have diastolic pressures elevating by about 10 millimeter of mercury. So intravenous are more likely to be associated with hypertension, and hypertension, if someone is hypertensive, withhold the EPO at the start, control the hypertension, and then start the EPO. Some of the factors which are associated with ESA-related hypertension include intravenous administration, patients on hemodialysis, and again, patients on PD. Family history of hypertension, if you are achieving a higher hemoglobin target, this was proven by the CREATE study, and a higher ESA dose. These are some of the reasons why you can have high blood pressures when on EPO. In fact, the possible mechanisms that have been explained is EPO administration has been associated with lower nitric oxide, circulating nitric oxide. It is associated with higher endothelin. It is associated with RAS activation. These are some of the mechanisms why hypertension occurs on EPO. Let's come to another interesting topic, which is pure red cell aplasia, which is mainly mediated by the IgG autoantibodies. Most often, they were reported between 1998 and 2002 when Eprex, which was one of the erythropoietin alpha, had uncoated rubber plunger, and when they interacted with one of the preservatives for the EPO, that is the PS80 uncoated rubber plunger with the PS80, and when it was administered subcutaneously, they were associated with the development of antibodies. So following this correction after 2004, there has not been much cases of pure red cell aplasia. A few cases of antibody-mediated PRSA have also been reported with darbepoetin also, but these are anecdotal reports and not as frequent as with erythropoietin alpha. So KDIGO guidelines suggest that an evaluation of pure red cell aplasia due to anti-erythropoietin antibody should occur in a patient who, in spite of being on 8 weeks of EPO therapy, drops his hemoglobin. He's been on at least 8 weeks of erythropoietin therapy, but his hemoglobin is dropping by about as high as 1 gram every week. He's requiring at least 2 blood transfusions every week. You start suspecting, okay, this patient may be having a pure red cell aplasia. He has a normal platelet and a normal WBC count. And most importantly, this is what is important. He has a low retic count. As against other causes, if there is an ongoing hemorrhage, or if there is ongoing, usually the retic counts are high. In pure red cell aplasia, the retic count is usually low. That's what we need to make sure when we are evaluating. So how do you manage patients who have had pure red cell aplasia? First of all, how do you identify this? Most of the centers would not have access to this. We may have to write to some of the authors, or some of the, we usually send to France if you're suspecting, and we send for its estimation. Radioimmunoprecipitation assay appears to be the most accurate test for detecting anti-EPO antibodies. ELISA are more widely available, but appear to have a lower sensitivity and specificity than the radioimmunoprecipitation assay. A biosensor assay, which is not as readily available as the two previous, has better characterization to detect the antibodies, whether they are IgG, whether they are isotype binding. They can better characterize by a biosensor assay. So ELISA is more commonly available. Then is the radioimmunoprecipitation assay, and then is the biosensor assay. How do you manage? Make sure that you stop all EPO preparation, including darbepoetin. You can't switch. I mean, just because he developed PRC on EPO, you can't switch to darbepoetin because it is again an EPO derivative, so you can't switch. Patients should be transfused if they're severely symptomatic anemic. You need to use immunosuppressive therapy for 4 to 6 months. The proven ones are the steroids with cyclophosphamide, cyclosporin, IVIG, and rituximab. All have been beneficial. It depends on the discretion of the clinician what they want to use, but they all are going to be beneficial. 4 to 6 months they may require the therapy for. KDIGO says they need, if someone has pure red cell aplasia, they can be put on EPO mimics, that is the peginositide. Let's come to the darbepoetin, our main molecule for tonight. How is it different from the erythropoietin? Both of them have the same protein structure. It is the 165 amino acids. But there are 5 substitutions, that is the amino acid substitutions in the darbepoetin, which try to make the long half-life, but more importantly, it is the carbohydrate. They are more glycosylated. They have 2 additional chain of glycosylations. So they are more negatively charged, 50 higher carbohydrate concentration, and they have a bigger molecular weight. The half-life of darbepoetin is at least 3 times that of erythropoietin. So if you're switching a patient from erythropoietin to darbepoetin, the simple conversion is for every 200 units, you need to change it to 1 microgram of darbepoetin. Efficacy of IV and subcutaneous darbepoetin is very similar, so you don't need to dose it according to the route of administration. Unlike erythropoietin, the elimination half-life after subcutaneous administration is around 48 hours. This in contrast of 8 to 11 hours for erythropoietin. So you often start with 0.45 microgram per kg once a week. But if you're starting For a kid who can't take weekly injections, or pediatric patients, you can go up on a twice weekly fortnight dose, or someone who is maintaining stable on a good dose, you can just go do a monthly dosing also. The other molecule, which is a long-acting, it is nothing but the SERA, which is a continuous erythropoietin receptor stimulator, receptor activator, which is a pegylated form of erythropoietin beta. The elimination half-life is again 130 hours. Just comparing to the 48 hours of darbepoetin, it is 130 hours. So often you can either use it once a month, or a fortnight, or once a month. The only drawback of this is very highly expensive, even though they reduce the number of doses that need to be administered in a month. But being long acting, but the problem is they are very highly expensive. So this was the molecules which were available in the previous decade. This decade has seen a lot of EPO mimics and the not directly targeting the EPO receptors. So there are molecules which are not directly acting on the EPO receptors, and there are EPO mimics. This is the list. This is the second generation FG4952, that is the roxadustat. We had the previous first generation, and the next one is the erythropoietic mimics. I'll be talking about the peginesatide and the HIF stabilizers. Peginesatide is what the KDIGO recommends for pure red cell aplasia patients. FDA has already withdrawn the molecule. KDIGO was the guidelines from KDIGO was 2012, and I don't think that holds any true now. Probably KDIGO needs to revise the section of pure red cell aplasia, because peginesatide has been withdrawn both in US and European markets, as well as from Japan. It is known as an EPO mimic. Basically, it has the same. Basically, why it came into existence, because what we told is for EPO, it's a recombinant DNA technology. Recombinant DNA technology is highly expensive, but what peginesatide do is it is exactly the same like an EPO, acts on the EPO receptors. It's an EPO mimic, but it's a synthetic molecule. So basically, it's a synthetic molecule like a chemical which can be produced in a lab at much cheaper cost. The advantage is it has much more stable, allowing it to be stored at a room temperature, doesn't require refrigeration, has a longer pharmacodynamic action, once a month administration, and because it is structurally dissimilar to the EPO, it can be used in pure red cell aplasia. The trials which have been done in peginesatide have been Emerald 1 and Emerald 2. Again, these were the trials which had to be discontinued initially. Emerald 1 was Emerald 2 were in the hemodialysis patient, while Pearl 1 and Pearl 2, this was comparing the EPO, and this was comparing with the darbepoetin. Pearl 1 and Pearl 2 were compared to darbepoetin. These trials had to be stopped prematurely and withdrawn for the reason they had higher cardiovascular events. Patients on peginesatide had higher cardiovascular events compared to placebo or EPO or darbepoetin. Not only that, there was also a higher hypersensitivity reactions, because being a synthetic molecule, there was a higher serious hypersensitivity reaction, and that's one of the reasons FDA, even though it approved both for IV and subcutaneous administration as a once-monthly preparation, they have now been withdrawn from the market because of a higher side effect profile. So the molecule which has garnered more attention in the last decade and a lot of randomized control trials have been, in fact, one of our centers in the center I practice also is involved. We are involved with the daprodustat, but lots of phase 3 trials have been done with roxadustat. What are HIF stabilizers? I'll just talk a couple of slides on HIF stabilizers because this is the molecule of this decade. Basically, it's a prolyl hydroxylase inhibitor, so it stabilizes the hypoxia-inducible factors. So what is it? Probably, it doesn't directly act on the erythropoietin receptors. It is an orally active drug, doesn't need to have an IV injection, an orally active drug. So basically, if you look at this uh, advantage of HIF inhibitor is it not only is just doing erythropoiesis, but also it acts on the iron metabolism. It reduces the hepcidin, improves the transferrin, increases transferrin receptors, ceruloplasmin, iron carrying proteins are all increased. It is also good for iron metabolism, also good for erythropoiesis. Basically, we have the hypoxic inducible factor. This is the prolyl hydroxylase, which normally HIF beta is constitutively expressed. HIF alpha is expressed whenever there is hypoxia. So HIF prolyl hydroxylase causes proline hydroxylation and inhibits breakdowns the HIF molecule, HIF alpha. So if you want erythropoiesis to continue, you want HIF alpha to combine with HIF beta and the process to be stable. So there are three types of HIF alpha 1, 2, and 3. What is more important is the 2 alpha. 2 alpha is mainly present in the kidney, while 1 alpha and 3 alpha are present in other organs. So the next, probably the third and fourth generation molecules that are HIF inhibitors should mainly concentrate on HIF2 alpha, because some of the side effects are mainly coming from HIF1 alpha and HIF3 alpha. HIF stabilizers also stabilize not just 2 alpha, but also stabilizes 1 alpha and 3 alpha. And some of the neoangiogenesis and tumor potency are mainly related to that. So once they are active, they bind to beta, and that's where they migrate to the nucleus and helps in the EPO production. So these are the trials which have been going on, the roxadustat, the vadadustat, daprodustat is what our center is being involved with, but there have been extensive studies with roxadustat. This is the article, this is the meta-analysis which was just got published about a week back in NDT, which talks about the efficacy and safety of roxadustat. Not much promising. I wouldn't say this is not even equivocal or not even superior to EPO or the apopoietin. It just qualifies to be used in non-dialysis dependent patients. If someone is interested in anemia management, they can just go through this meta-analysis. Overall, what it says is in non-dialysis dependent, it is equivocal, but in dialysis dependent patients, it's not superior. In fact, you don't have to watch for it. Some of the gray areas with HIF inhibitors have been basically the pill burden, the compliance. I mean, some of these tablets have to be taken every day or every other day, especially in pediatric population. This can be a problem. No one knows about the cost. They have still completed the phase 3 trials, and once they come into the market, one knows about the cost of it. Even though they say that the response to hemoglobin rise is 1 gram per deciliter in a month, but it's not as smooth as it is claimed. One of the main gray areas is about the neoangiogenesis and the vascular endothelial growth factor, which is also HIF dependent. This is also HIF dependent, and that is the reason HIF2 alpha targeting molecules should be the third or the fourth generation molecule should be the one which we need to look forward to, and not the current. Because in fact, when you go through this meta-analysis, it talks about at least 6 to 7 studies, and none of these studies had a follow-up period of more than 6 months. They were all short-term studies, not actually looking into the long-term effects of HIF inhibitors. And definitely, they are more likely to be oncogenic, especially with the neoangiogenesis. They are known to reduce the blood pressures and the drug-to-drug interactions with other medications, especially CKD patients who are on phosphate binders, etc. Not known. Gene therapy is probably at its nascent stage. It is still in the animal models it's being used, where they try to introduce the human EPO gene, and then probably you don't need to be on any other drugs. Probably this is something which probably in 2 decades time, probably this is what the future holds. To conclude, the primacy of a clinical judgment is important. Treatment should be individualized. The aim should be first do no harm. Use ESA sparingly and attempt only partial correction of anemia. Try to keep a target between 9.5 to 11.5. Don't go overboard. It is still not known whether ESA dose or the target hemoglobin level was the cause of adverse event. No one knows whether it's like high hemoglobin is in all these trials led to increased vascular thrombosis and stroke, or whether it is ESA per se. HIF inhibitors, HIF stabilizers have the advantage of improved iron metabolism, especially in patients with functional iron deficiency. It is extremely well. However, long-term safety, especially with respect to neoangiogenesis, needs to be studied. Darbepoetin seems to be an ideal choice currently in terms of anemia management, especially because of its long half-life, the cost, and easy accessibility. Thank you.
Thank you very much, Dr. Dharshan, for an extensive talk. I would like to welcome Prof. Kaima, who is present now. Prof, we can basically take just one question since our time is almost up. And then subsequently, we'll move to the parallel sessions. So before we move to the question, I would just like to announce that for those people who want to stay on and attend the critical care session, you just stay on the same link. For those who want to attend the transplant session, it's on track 2, and the hypertension and the kidney session is on track 3. We have provided the links in the chat. So if you just click on the chat, you will get the links for track 2 and track 3. Prof. Kaima, you can just take one question, and then we can move on to the next sessions.
Yeah, thank you so much, Professor. I hope I can be heard.
Yeah, I can clearly hear you.
Thank you. Thank you, Prof. That was a wonderful presentation. There are quite a number of questions if you check, and I think probably you type out the answers for the participants. But there's something about the cancer.
Yeah.
Cancers, if a patient has got CKD and they've got cancer of the prostate, would it be safe to use? And probably that applies to other malignancies, of course.
Yeah.
There's been controversy whether it's really safe or not safe. Any comments on that?
Yeah, I'll try to answer in general. I mean, prostate cancer is a part of a general malignancy, so I would detail in that way. Any patient with an active malignancy, try to avoid erythropoietin stimulating agents as well as HIF inhibitors. Active malignancy, no. But in patients with previous malignancy, it has to be individualized. What is more important at this point of time is a detailed evaluation on what you are doing with the malignancy. Are you going to treat it completely, cure it, then avoid EPO? But if you are doing palliative care, if you are saying that, okay, no, this is an advanced cancer, I'm just going to do a palliation or a symptomatic treatment, I'm not going to cure this disease, then EPO is the answer for that. So in cancer-induced anemia, if you're going to actively treat and your aim is to completely cure the disease, avoid EPO. But if it's an advanced disease where palliation and conservative therapy, you try to use EPO to improve the symptoms.